Because
Yes.
I'm asking about patients who are in the first line setting, but they do not fit the trastuzumab resistant. So they receive trastuzumab plus pertuzumab in the neoadjuvant setting, and they relapse after more than 1 year. So what do you do for those patients now?
So usually, according to the current guidelines, you give pertuzumab, trastuzumab, and taxanes. So if you relapse after more than 1 year, if you have a relapse within 1 year, you should propose trastuzumab deruxtecan. We have 2 questions on this in the consensus that we will have tomorrow. Because of course, until you don't have the data comparing trastuzumab deruxtecan versus pertuzumab, trastuzumab, and taxane, the study is ongoing. So we will have the data in 2 years from now. Still, the standard of care for patients relapsing after 1 year, after 12 months, is still pertuzumab, trastuzumab, and taxane. TDX is for second-line therapy or for patients relapsing within 1 year outside the Cleopatra inclusion criteria.
Shift that the lesion will, or the breast lesion will be low or ultra low. Are we going to re-stimulate it again, re-challenge it again?
So if you have an HER2 positive disease in the baseline and then in the relapse you have HER2 low, this is an heterogeneous disease. What we are doing now is to consider this still HER2 positive. And now you have trastuzumab deruxtecan that works both in HER2 low and HER2 positive. So TDX is an option for all seasons, finally, because you can give it for both the population. This is impressive because if you think about this, my friends from AstraZeneca will understand. Can you imagine what will happen once the drug will be approved all over the world? So it means that you can give this agent to HER2 positive, HER2 low, both HR positive and triple negative. And if the Destiny Breast 6 will be positive, you will give also to HER2 zero. Okay. So it's, I don't know any other drug beyond the immunocheckpoint inhibitors with this type of target. That's why I believe there will be no expanded access for HER2 low disease, maybe for HER2 positive, but for HER2 low is unfeasible, of course. It's, I believe the ADCs will replace chemotherapy in the future because this is the beginning, but datopotamab deruxtecan, I don't know if any one of you tested it in a clinical trial, is a very potent and powerful drug like TDX, but in the triple negative population. And in the future, we will have sequence of ADCs. You will start with one, then you will give another one, changing the target and the payload. So it's a revolution, this one. It's really a revolution.
What about if the recurrence in the low burden disease, if it's low burden?
Yes, this is, I like this question because in a provocative way, I said, why don't we think to cure low burden disease? So if you have a patient, de novo metastatic, with one single liver lesion or one single lung disease, let's say that you will have approved TDX in the first line, you will treat this patient and she will achieve a complete response after 3 cycles, and then you go on in the metastatic disease. Who can tell you that this patient that is metastatic, low burden, is not cured? You know, we are giving now trastuzumab or trastuzumab, pertuzumab for several years to patients that are in complete response. You have patients in the metastatic setting with complete response. And we do not discontinue the dual blockade because we don't know if the tumor will reappear or not. But now you have a drug with a very high therapeutic ratio. So maybe we can design a clinical trial to understand if we can cure metastatic disease. This is not a dogma. In testicular cancer, you can cure a metastatic testicular cancer. You can cure a lymphoma. Why not an HER2 positive disease? So we need to check this hypothesis, specifically in the low burden disease, because there is less heterogeneity, and maybe you can broke this dogma. So can we cure oligometastatic disease? This is the next challenge for AstraZeneca and Daiichi Sankyo. Yes, please.
As you have shown, in HER2 is moving from third, second, maybe in the first line, maybe also in patient with non-PCR.
Neoadjuvant, who
and the
knows?
adjuvant setting. I'm searching where will we give Herceptin, trastuzumab itself. I wonder if, you know, in the pathological report, when they give us the definition of HER2 +3 or positive, it means that there is strong expression in just 10% of the cells.
Correct.
I think if we want to select the patient who will benefit from Herceptin, if the pathology mention how much cells are expressing the HER2, if it is 90%, 100% of the cells are expressing HER2, I think these are the cases that may benefit from just Herceptin.
Yes.
They do not need ADC with its expensive. I'm just thinking where we can place Herceptin if trastuzumab deruxtecan is moving in all the aspects of the disease.
If the first line study comparing Cleopatra regimen to TDX will favor TDX, of course, you have to give to the patient the best treatment available. So the median progression-free survival of Destiny Breast 03 is better than the Cleopatra one. You know, I don't know what will happen in the neoadjuvant setting, because let we see, we have a 3-arm study that is trastuzumab deruxtecan for 8 cycles. TDX followed by paclitaxel, pertuzumab, trastuzumab, and then the standard of care. You know, let we see in the neoadjuvant setting what will happen. But, you know, the definition of HER2 should change following this data. This morning, Viale said that ESMO is working on a new definition of HER2. I am leading this group because it's a group of pathologists, but many medical oncologists are included. We are going to publish the paper, I believe, in 1 month from now, because we completed in these days. So the new definition of HER2 should take into account not only the numbers and the rate of cells that are positive, but the spatial distribution of the cells. And once you will report as a pathologist HER2 status, usually you write, okay, we have 1+ in tot % of cells. Maybe you have to report how many are 1+, how many 2+, how many 3+, because this will better understand us what we have to do. And we are asking to AstraZeneca to do this in the neoadjuvant studies, because this is a very good opportunity also to change the ASCO-CAP definition. Because if not, you will give TDX to everyone, and one size fits all. And AstraZeneca will be very happy about this, but maybe there are some patients in which you can de-escalate. Yes.
Again, what about in HER2 positive? I'm not speaking about HER2 low.
Yes.
What's beyond TDX? What is after TDX?
Yes.
Still some agent like TDM1 is still active, or if I start with it and I have this marvelous response and my patient progress later on.
This was the title of my talk at ASCO this year. The question was, what after TDX? So, you know, up to now, you don't have any single study after trastuzumab deruxtecan. So you have several options. You can give tucatinib, trastuzumab, and capecitabine. You can give also TDM1. TDM1 is another option. You can give lapatinib and capecitabine. You can give neratinib and capecitabine. So any other option that has been tested after TDM1 can be proposed, of course, after TDX. But for the future, I believe we need clinical trials after trastuzumab deruxtecan. My proposal is let's wait for the first line study, and then let's design new trials in the second line, because if TDX will be the new standard of care in the first line, it means everything will be anticipated. And then we need new data in the second and third line. Very good question, this one. Yes, please. The microphone, yes.
Difficulty in this question, when we have progression on ADC, we don't know the progression is for the trastuzumab or for the
or
drug
the
conjugate.
payload.
For the payload, we don't know. Yeah.
This is another important question. You know, we need studies in which we retest, of course, sequential biopsies to understand if you have a downregulation of HER2, or even if HER2 is still high, maybe the mechanism of resistance will be related to the topoisomerase inhibitor. You know, I like the study they did with sacituzumab govitecan. In the ASCENT trial, they evaluated the mechanism of progression, and it was related to the enzyme activating govitecan. So we need similar study also for trastuzumab deruxtecan, but we are going so fast, so everything is changing in 6 months. So that we need the time to stop and to understand better which is the mechanism of resistance. Yes. So we move to the next talk. There is a last question and then the next talk. Yes.
Dr. Giuseppe, if you have a patient with HER2 score 2, stage non-amplified, hormone positive.
Two positive, 2
Yes.
plus with FISH
Plus two,
non-amplified.
yes. Would you choose to do TDXD or go for CDK4/6 inhibitors?
No, in the first line, up to now, I will go for CDK4/6 inhibitors because it's still the standard of care and there is an overall survival benefit. So you cannot ignore the data of the trial. So my first line is still CDK4/6 inhibitor plus endocrine therapy. Yes. Okay, please.